Hello and welcome to the International Forum on Quality and Safety in Healthcare, Amsterdam, the Netherlands. My name is Nicholl. The theme for this panel discussion today is My Team Plus Me Equals Patient Safety. I'm delighted to say that joining me to discuss issues on this theme are Rein Willems, who's former president of Shell Netherlands and a member of Parliament for the Christian Democrats Party in the Netherlands, who brings a wealth of experience, in particular to safety in industry. Next to Rein is Emily Friedman, who is assistant professor in the School of Public Health at Boston University, and who also acts as an independent health policy and ethics analyst in the US. And to her left is Cathy Torpie from New Zealand, who is a psychologist with an interest in improving communication for both patients and staff within healthcare. Now, just by way of background, New South Wales Health comprises 15 local health districts responsible for providing health services in a wide range of settings, from primary care posts in the remote outback to metropolitan tertiary health centres. In addition to that, there are 3 specialist networks, 4 statutory clinical bodies supporting clinical practice, and an ambulance service responsible for the delivery of frontline pre-hospital care, medical retrieval and health-related transport. And I think it's fair to say that New South Wales is recognised nationally and internationally as a leader in improving the quality and safety of clinical services provided to patients, with a number of organisations being created specifically to focus on improving patient safety and clinical quality in the system. And these include the New South Wales Agency of Clinical Innovation, which is designed to review clinical practice and reduce unnecessary clinical variation through the development of best practice evidence-based models of care. In addition, there's the New South Wales Clinical Excellence Commission, which is designed to review trends in adverse incidents, improve practice and enhance quality improvement capacity in the health services. Significant funding has been provided to establish systems and structures to improve patient safety and clinical quality throughout the system, and these include the establishment of clinical governance units in each local health district, the rollout of a recognition and management of the deteriorating patient program, infection prevention and control strategies, and improving medication safety. In addition, there's a coordinated approach across Australia for the improvement of safety and quality in healthcare through the National Australian Commission on Safety and Quality in Healthcare, which leads and coordinates improvements in safety and quality in healthcare in Australia by identifying issues and policy directions, recommending priorities for action, as well as disseminating knowledge and advocating for safety and quality. Even with these significant systems and structures that are in place and the dedicated funding support to improve patient safety and clinical quality provided through the healthcare system, it would not be true to say that every doctor, every nurse, every midwife, every allied health professional thinks that patient safety is a primary responsibility for them and their team. In the following discussion, it would be of great benefit if the panel could consider this particular dilemma in the following questions that we're going to probe. So if I could just open up the questions to the panel. And the first question, when should a complication be an adverse event?
Well, to start with, I think a complication is, in healthcare, in my view, everything that could potentially result in a more dangerous situation, affecting health and life of people. And people at the workplace generally know pretty well when something potentially could go wrong after a certain act. And it's those type of things that you started registering over time and start to learn from that as a team on how you can avoid that these things happen. Because the potentially unsafe things are actually the things on the bottom of the iceberg, which you don't see, but are the cause of eventual accidents that could happen. And it's those things that you need to review as leaders in a department and learn from that and see how you can avoid those. Because it's only those events that you can actually manage in a continuing operation in a department over time. But as I said, you expect that to be reported in a blame-free manner. Please report them so others can learn from them. And in such a process, which generally is called blame-free reporting in healthcare, then indeed people can learn to avoid that these things happen in the future.
Emily Friedman.
I think in the perspective of ethics, any adverse event has to be reported. I agree with Rein that it should be done in a blame-free environment. It must be done. Otherwise, we get the blame game, the intimidation, cover-ups, things that can, as Rein said, really create problems down the line. But there is a positive aspect to this. Educators talk about what they call a teachable moment. And a teachable moment is any situation in which something occurs that can help a child to learn. Any adverse event, any complication, anything that went in the slightest way wrong or went the way it was not expected to go is a teachable moment. It's not a situation for penalty. It's not a situation for blame or for any kind of punishment. But it should always be reported simply for the purposes of learning and of seeing that it doesn't happen again. In, excuse me, in clinical terms, there is the concept of the sentinel event. And a sentinel event is something that in itself causes no harm, but it should cause concern that something bad could happen because this situation exists. An example would be the lighting in a mine appears to be faulty. Now, the miners are not in danger per se, but if something happened in that mine and the lights are out, then the miners are in grave danger because they can't find their way out. That's a sentinel event, and I think any complication should be viewed at the least as a sentinel event.
Kathy Torpie, do patients differentiate between adverse events and complications? Do they see them differently?
I don't think that they would necessarily see them as differently. I think that any patient that I can think of would want to know if there was any kind of a problem. We don't think quite in terms of sentinel events or adverse events, but if there was anything that wasn't exactly right, then it's important to communicate that to the patient so that the patient is aware, so that the patient has more trust in their doctor or their clinician because they know that whatever has happened is transparent, that they can trust this person's going to tell them the truth, is going to follow up on that, they've got their back, so to speak. So no, I don't think that there should be any difference between one and the other, but that all things should be reported not just in-house, but to the patient.
Thank you. So Kathy Torpie, if I can just stay with you,
Okay.
Is there value in educating patients or the broader community about safety in healthcare? And how can this be done without frightening them?
Well, it's a really hard question not to answer but to hear, because you're asking whether or not I should be involved at all in my own care. I can't be responsible for my own health and my own ability to participate without having all the information that's necessary. And so, yes, I should be given information, and I am much more frightened by what I don't know than by what you can tell me. If you can tell me what the risks are, and I've had several operations, and I always ask, what are the risks and what are the possible benefits? And I want to know how one outweighs the other because it's my choice and it's my life. And without that information, I feel I would be being cheated of something, if that answers your question.
Thank you.
Could I
Emily,
add a bit on that? To use an American phrase, I think the cat's out of the bag on this one. If people are going into surgery marking not this arm in permanent marker, not this eye, this leg, not this leg, then I think patients are already frightened. And I don't know a great many people, I mean, Kathy is obviously an expert here, I don't know a great many people who look forward to surgical procedures. It is an inherently frightening situation. The empowered patient who has more knowledge, who knows the cost, the benefits, the possible risks, is going to be less frightened than a patient who is going, somebody's operating on me and I'm scared.
Yeah, thank you very much. Emily Friedman, if I can just stay with you now, how can we make health policy around safe practices meaningful at a local level?
Well, I think it has to take the form of empowerment of healthcare workers, healthcare professionals, providers at that local level. Having top-down pronunciamentos doesn't work very well. Hello, this is our quality policy and you will all adhere to it. It doesn't work, especially because, and I have learned this from studying disaster situations, from work in Cambodia and other places, it is the people on the front lines who know what's going on. When Rein was running Shell, he had superb policies in place. But if you don't have people on the ground, on the front lines, on the local level going, that's wrong. We tried it, it doesn't work, we think this is a better idea. You will not get acceptance, and you also will not get improvement. But it has to be empowering. It has to have a grassroots, involving, and respectful environment to it. Or it's just going to be one more piece of paper that came down from headquarters.
How do you get local people to get involved in policy making, policy decisions? How do you generate grassroots level?
Ask them what they think. Ask them what they think. I don't care if it's a suggestion box. I don't care if it's meetings that are simply discussions, where one of our speakers at this conference, who is in Japan in Fukushima Prefecture, very close to the exclusion zone, working under extraordinarily difficult situations. And at the Fukushima University Hospital, they have a meeting of all division heads and all department heads 3 times a day going, what's going on? Are you seeing problems with radiation? What kinds of injuries do the patients have? What do you need? What can we do about limited water supplies? What are the priorities? They're doing that 3 times a day. In normal circumstances, you don't have to, but it should be done regularly. And again, seeking input, not pro forma. What do you think?
Can I add something to that also? I've noticed that there's, in a lot of the patient surveys, the criteria seems to be based more on the values of management or clinicians than on patients. And so when you get a multiple choice or a yes-no kind of question, it doesn't necessarily, if it's not the criteria of the patient, it doesn't necessarily address the patient's concerns. So I think when you ask those questions of the local community, they need to be open-ended questions.
Thank you.
I would add just a bit on that there is a new mania in many healthcare systems around the world for patient satisfaction surveys, which are supposed to be a proxy for clinical quality. One, they are not a proxy for clinical quality. They're a proxy for patient satisfaction. 2, they should not be worded or presented in such a way as to make the provider look good because they are being ranked by someone. I absolutely agree with Kathy. If you're not going to allow open-ended discussion, then don't bother.
Thank you. Emily Friedman, if I can just stay with you, from your research and your experience, what evidence is there of the things that really change practice to improve patient safety?
Well, it generally is considered to be either carrots or sticks. And from experience in my country, I could tell you that the trend right now, start out with a carrot, but if that doesn't get them attention, then hit them with a stick. An example would be as part of our new very extensive healthcare law that was just passed, about which there's a good bit of controversy. There is a real nudge, shall we say, there's a real push to get physicians particularly to adopt electronic prescribing, electronic health records, and health information technology, all of which I support, by the way. And there are financial incentives right now because for a small medical practice, getting into this can be a bit expensive. But if you don't do it within 3 years, they're going to start docking your pay. So that's one way of incentivizing people, if you wish. However, it is my experience with clinicians, particularly with physicians and nurses, if they see that something works better, they will adopt it if the system allows them to do so. If you see better outcomes for patients, happier colleagues, more efficient processes, better use of resources, people will be glad to adopt it. And the question is, will the system let them do so? I think the more difficult issue, and Rein, I would very much like to know your views on this, is if you think of a bell curve, something comes in, electronic prescribing. You have early adopters who are sort of the pioneers, who are very eager, the people who stand in line to buy the latest iPad, right? Then in the middle you have most of the adopters. But then you have that tail at the end of people who absolutely will not change. The recalcitrant, the resistant, the opponents. And they can sabotage change. They can sabotage adoption of better ways to do things. And Rein, I would be very interested. What do you do about them?
On particularly the patient safety program in the Netherlands, using your bell curve, which I think is a good example. The early adopters, they have already moved. The rest you let follow by really assuring a cultural change in organizations. When the leadership in hospitals takes on the attitude of, yes, we think it's important, we'll do, then you get those people to do it as well. And the last group of people, unfortunately, I think they're the ones that you only can get along if you adopt laws in the country and use sanctions against them. Because they are sometimes intransigent, sometimes they don't know, sometimes they are not computer literate, or you name it. There's also the reason. But yes, that last group of people you have to, but I have a long time to the government here advised them, when we started our program in the Netherlands in 2004, the first 4 or 5 years, don't put in any new laws. Start with programs at the hospitals and let the cultural change do it. Because the moment you set up a law, even the big middle group that you were talking about will adopt an attitude of ticking off boxes.
Yeah.
Rather than adopt an attitude of it's in the culture of our organization that patient safety is there to be and is important and is part of our work life. So that's the way I think we want to do it. But yes, a law only at the end, and you have to at some stage put in certain legislation to make sure that you guarantee minimum standards in society.
And that is the issue. If there are people who simply will not be willing to meet minimum standards, then they have to leave the system.
I'm not going from the assumption that people are purposely trying to disrupt the system. I think generally people working in healthcare have an attitude that they're there to care for people. I mean, there's very few people there, maybe the 1 or 2 exceptions in the world, that are there to kill people. So the attitude is one very basic one. So the group is generally, the group laggards is generally one of people who are computer illiterate or are close to retirement and don't bother anymore, or, well, you can name a few more probably, but in the end I think those you have to get by making sure with legislation or rules or sanctions. In the first case here in the Netherlands we had a situation where a hospital was clearly in violation of the basic standard rules in the operating room. And I told the inspector, they said the only way to teach those surgeons, and by the way, the surgeons were the last to adopt patient safety programs.
This does not surprise me.
And the only way to teach them is in the end that you close the ward. You have the authority to close the operation ward for 4 weeks until they have the house of order. Let them feel it in their pockets, and then you will see change. And lo and behold, in the 3 or 4 times it's been done, the changes were dramatic.
I might just continue on with Rein. it's been 7 years now since the launch of the safety management system in the Netherlands, and you've just touched on one of the aspects there. Can you tell us what's been achieved so far, and what's the evidence for any improvements that you've seen?
Yeah, if I look at that, we set ourselves the target. We set the target for the people in government and the hospitals that in 4 years they should have a blame-free patient safety reporting system or blame-free incident reporting system in any hospital, any of the 100 hospitals in the Netherlands, in 2008. And this was based on an experience at the own company that I worked for. If you introduce such a program, it takes you 2 years. And I said, well, here, hospitals, all with own boards, no government that can centrally authorize them, it will take twice as long, 4 years. The situation after 4 years was that probably 70% of the hospital had started with something like, in one or two few departments, of a blame-free incident reporting system, but no integral system throughout any of the hospitals. Only now, in 2011, do we see that there are a number, and are still less than 10, that have a fully comprehensive system in all hospitals. All hospitals have started with the program. All have started with the cultural change, but it's taken a lot longer. And I have, again, advised ministers in the last couple of years, don't go with legislation yet, because it is still part of the cultural change. It will apparently take a lot longer in the healthcare than, yeah, but the moment you start with legislation, and half of the people feel it's important and the other half not. The other half will start ticking boxes and say, okay, we have to do it. But you have to take them along in this cultural change. Are there ways to improve that? Yes, I think there it's essentially the leadership of hospitals, which are basically all private hospitals in the Netherlands. And here we are thinking with government on how can you coerce those people with sanctions in the boards to make sure that they take these things seriously.
Just extending that a little bit, what role do you see for key performance indicators?
Well, there are the present inspectors in Holland has a series of indicators for performance of hospitals, and there are far too many. I think there's over thousands of them, and it's like registering them, a lot of paperwork. To me, in the end, there is only one simple one which could work for ranking hospitals. That's the hospital standardized mortality rate. When this thing was introduced first in Holland, and it's still in the introductory states, but the hospitals are still arguing, well, you know, the situation in the hospital is slightly different from all the other hospitals. We have these particular cases much more in our hospital than those, so it doesn't really apply to us. That's why we're a bit lower, but we should actually be a bit higher. Those type of discussions occurred in the beginning, but in the end, I think it's a very simple method to have a hospital look at their performance and say, why are we at the bottom of the list, or the bottom quartile of all hospitals in Holland when it comes to mortality? And start then working out programs on how to do it and learn from others on how to improve it. It's as a one single standard measure. It's the same measure that Shell plants in the world use. We have standard at any entrance of the refinery or a chemical plant, a plaque that says what is the lost time injury frequency rate, what is the and what's the lost time injury rate. The lost time injury rate means how many person hours worked without loss of injury time. And the higher, the more millions of hours worked, the better your performance is. And I tell you, it works as an eye catcher for everybody coming in. Hey, this is a safe place where people are working safely.
Yep.
And, excuse me, if I might add to that.
Yeah.
It also, having the plaque, it's common in American industry.
Yeah.
We have gone so many days without a worker being injured. And then it gets to be a competition.
Years.
It becomes competition. We want, well, they've gone 356 days. We've gone 400 days. Anything you can do to get people to compete to do better. Also, just to back something up, there's a wonderful story from the United States from the work of Dr. John Wenberg, who is a pioneer in this area. And there was a hospital in Vermont, which is one of our states, that had a very high rate of tonsillectomies, about 10 times what it should have been. And one of the physicians got interested in this. And he proceeded to post a list in the doctor's lounge of all the hospitals in Vermont. There are only about 15 of them. And how many tonsillectomies per population were done. And the tonsillectomy rate dropped like a stone. When that doctor retired, it went up again. So the information loop, the sharing of data is absolutely critical.
If I can just change the focus for a little bit and ask you, Emily and Kathy, in particular, how can we support safe care in smaller communities? And by that I really mean the geographically isolated ones, and we do have those in New South Wales, or for vulnerable populations, particularly the indigenous people, given the needs for skill maintenance, clinical networking, workforce, all those things that we see as important.
Well, there is a problem in healthcare systems around the world. I mean, perhaps not in Singapore, but just about everywhere else. And that is a shortage, to begin with, a shortage of clinicians in rural areas. You see it in Cambodia, in Canada, in the United States, in Australia. Well, research has been done on why people don't want to practice in rural areas. Number one reason is my spouse doesn't want to live there. The number two reason is isolation, clinical isolation. What's going to save us here is the technology. People coming out of medical and nursing school today will barely remember a time when there was not an internet. We are moving toward electronic prescribing. We are moving toward electronic health records, toward very large clinical databases, telehealth, telemedicine, remote learning, such as what we're doing today. That's going to make it much easier for the isolated clinician, particularly those serving very small indigenous communities. It's going to make it much easier for them to use an American phrase, keep their chops up, to keep clinically up to date, to have conversations with colleagues. If you think about your work or any of our work, you don't want to be sitting alone in a cave with no one to talk to about your work. So I am so excited about the entire spectrum of information technology and what that is going to mean for skill maintenance, for collegiality, for learning, and for knowing the latest best practices and being able to communicate best practices even to people working in very, very isolated circumstances. And I think it's a very exciting time.
I'd like to add to that I think that when you're in an isolated area, one of the things that could be of benefit is going in and bringing training to local people so that they can combine, if it's an indigenous group, for example, so that they can integrate some of their own practices and beliefs with modern medicine so that a level of health can be maintained. A benefit of a small community is that everybody knows each other. They already trust each other. There isn't that fear of some outside expert coming in and telling them what to do. I lived for some time in Guatemala, and a lot of people who needed to go to the hospital from the pueblo wouldn't go because they thought that this is where you go to die. So using the benefits of what you do have being in an isolated area isn't necessarily a negative thing. There are positives, and I would pick up and use them as a resource.
And I would add that respect for traditional healing practices is essential if you are working with an indigenous or a minority community. I have seen this all over the world. Western providers come in with their jackboots on and have absolutely no respect for the shamans, no respect for the monks, no respect for ceremonies and so forth. The healing of the mind and the power of the mind in healing is very, very important. But the emotional comfort that traditional practices bring to the patient is equally important and is part of healing. And integration is necessary, but also having respect for people who do it a different way has to be part of it. Thank you.
My last question is about technology and high-tech advances. Do they have both positive and negative impacts on patient safety?
Well, I can hardly think of any negative ones, but let me mention a few positive ones. And it starts from the belief that what I've seen with the rising cost of healthcare, technology is the only, and particularly IT technology, the only thing that can really help us bring down cost over time. But a couple of areas. We talked earlier in the discussion with my colleagues here about the whole system of electronic records. If one thinks that measurements in the last couple of years, 3 years ago, we did a measurement in Holland, or the health authorities did a measurement, the amount of death in the Netherlands as a result of, annually as a result of errors in hospitals, it is amounted to about 1,700 on a population of about 70 million. Which is about what we expected when we looked at other statistics in other countries. Of those 1,700, 40% was related to medication errors. Decimal points the wrong way, or in handover something written with handwriting written and people not able to read and made something up themselves. I mean, a whole host of things. 40% of medication errors, and those things you can, for 99%, get out if you if you use good electronic data transfers. And hospitals are working with that, with electronic medication systems. So that's one area, medication. I think learning from simulation. The process of simulation processes in operation techniques or in all sort of medical handlings. There's a whole organization now globally and in Europe that has been set up to advance the simulation techniques in training programs of people. And then all the technology of microsurgery, where you use very fine technologies to not have to make very large incisions anymore, which are far less invasive. So yes, I'm a great believer that technology will be able to bring down cost. Are there disadvantages? I think the risks and disadvantages are always be that there is a certain fear by people of new technology. Anything you introduce new in a society, when it's high-tech, people have an inherent fear that because they don't know the details, they think that may get wrong. Around the electronic data records, we have in Holland a unbelievable fear about privacy. That you can't start a thing. Now, the electronic data records exist at the moment in 70% of the hospitals with their doctors. Now the government wants to centralize that with a system where you can transfer from one region to another. So if you have had an accident in one place and you're not close to your hospital, that they can access via certain codes to your records. This was voted out in Parliament last week for the simple reason that people believe that it's unsafe and the lack of then knowledge, also the lack of good communication, stop these things. So yes, there are certain disadvantages still, but I believe they can be overcome.
Emily?
There are many ethics issues involved in this. To take up the privacy issue, in every survey that has been done of Americans, their number one fear about electronic health records and about electronic prescribing is privacy. Now, in my country, because we have a rather cockeyed way of paying for health care, the fear that your employer will fire you because your employer finds out that you have HIV, the fear that the insurer will not treat you anymore because you were found to be diabetic, there's actually quite a decent basis for the privacy concerns. But the ethics position, and I think this is pretty universal, is that, and remember, I love these technologies. I love the whole IT thing, but Kathy's medical records are none of my business. So I think that's one issue. And the second issue is people love toys. It's just very simple. People love toys. And I think two issues with technology is that the trend tends to be to augment rather than to replace. We started out with x-rays, then we got brain scans, then we got CT scans, then we got MRIs, now we have PET scans. And there are many patients who go through all 5 of those. So the temptation to overuse technology, which is wasteful and also can be of risk to the patient, and the tendency to want to play with your toys has to be counteracted by quality standards and quality programs that are just as applicable to pharmaceuticals and to medical devices as they are to the procedures themselves.
You know, I think here and in other conversations I've had, we come up with a theme, whether we're talking about technology or legislation or whatever, and the theme seems to be trust. You know, whether or not the rural or indigenous person trusts the clinician, whether or not the patients trust their information being available publicly, whether or not the clinician trusts the patient if they reveal that they might have made an error. There is a culture of mistrust, and we have a lot of different immediate solutions that we seem to look to rather than looking at what kind of relationship do we have, and should we start right there at the bottom at looking at that, how important that is, because that can enable some of these other solutions to actually work. In my work as a therapist, as a psychologist, I noticed that when people have a problem, they tend to repeat the same kind of solutions, but they'll often up the ante if the solution isn't working. You know, so if you're a parent who shakes a finger at the kid and it doesn't work, next time you might yell. You know, you might put them in their room, or you might, keep them from going out for a month. You just up the ante. And in medicine, it often turns out to be that what we'll do is we'll make new policies and procedures. And it's the people that make policies and procedures useful or useless, make the technology useful or useless. I agree with you about the mistrust and those issues. I would say one really good way of using technology is with the remote consultation. Often people don't have access to medical care because they can't get there. But it is possible to be able to see your doctor on the screen and have a conversation. That's possible anywhere in the world.
We even have some good experience in the Netherlands in a trial program, what's called e-health on psychiatric care, where in the Amsterdam area here, the number of suicides in that region has dropped dramatically to about half of what it was before, because people were able to contact, be able to talk, and it apparently anonymously, but they knew they had contact with somebody and were able to answer things. And I'm sure that in all parts of the world people have similar type of programs, but e-health I think is going to be an important element in the future. And
one of the unintended consequences of some of these technologies that we are also supportive of is precisely the anonymity.
Yeah.
There's a concept in ethics and philosophy called the Cascade of Consequences. Well, one of the consequences that has cascaded down from email and the internet that no one really planned on is that people feel more secure for it. People who are shy, people who are struggling with depression, people who may have been, I know this sounds problematic, but Kathy can certainly speak to this, people who have been disfigured in some way, who don't go out much, who may have sustained burns or some other injury. You can still talk to a provider. You can talk to Kathy on the internet without a camera. You can talk to her remotely without being viewed. You can look at her, she doesn't have to look at you. And that form of privacy, that form of security, I think is going to help build trust. No one ever thought the email or the internet was going to produce that, but I think it's one of the good things that's coming out of this.
And I've actually seen that happen. There have been a couple of occasions, more than a couple, where people might have read my book or heard my story, and I'm easy to find, and they contacted me. And we created an ongoing relationship until they could move on, and they played it forward with other people.
Well, I think we have to draw it to a close now. So, Rein Willems, Emily Friedman, Kathy Torpie, thank you very much for your time today.
You're very welcome.
Thank you.
Thank you
very
for
much.
asking
Thank
us.
you. Yeah.